Welcome everybody to this last workshop webinar of the ESSM. Very happy to welcome you to this. And as you remember, I'm sure these are warm-ups for our conference coming up very soon. Tonight's workshop is about the BPH medical and surgical treatment and how to deal with sexual consequences of these very common treatments. And this is something I've been looking forward to very much as a urologist myself. Tonight's speakers are going to be Javier Romero-Otero. He's a professor and director of urology in Madrid and one of our executive committee members of the ESSM. And he is responsible for initiating tonight's webinar. And as a speaker, he'll be joined by Professor Andrea Salonia, a former scientific chair of the ESSM, and currently, among other things, head of research at San Rafael in Milan, co-editor of the Journal of Sexual Medicine, chair of the EAU Guidelines Panel on Sexual Health, and arguably one of the most influential andrologists in the world today. And our conference coming up that we're warming up to, just to remind you, it's going to be very soon on February 19th to 20th, 2021. So if you haven't already, please do sign up for this via the website. And the main guy responsible for the scientific content of this Congress is our current scientific chair, Giovanni Corona, and he would like to say a few words before we start the webinar tonight.
Thank you, Mikel. Good evening to everybody and welcome to this last workshop webinar. We did a large amount of webinars since last June with a great success. First of all, webinar related to statement, and then from September related to workshop, so more clinical oriented workshop. Tonight we have a very best speaker, so great speaker, Andrea Salonia and Javi. I'm sure that they will cover the topic very well, so enjoy the webinar. Please, Mikel.
Yes, and just also a few words from our president, Carlo Bitocchi.
Well, thank you very much, Mikel, and good evening, everybody. I just have the same sensation of Giovanni. I'm quite happy and excited to have both Javier and Andrea to really cover a very important topics for us as urologists. I just want to spend a really few words about the importance of our educational program. As you know, we are now very much close to the meeting that this year, unfortunately, for the first time, will be not physical but virtual. But having said that, we're really looking forward for having all of you together. And a few other words about our educational projects, and you can see from the slides that is just coming now. Basically, we are still focusing very much. Well, I think they're moving very quickly today. Okay, we are focusing very much as usual on our ESSM School of Sexual Medicine that now we have together with combined with the ESSM Advanced course on sexual medicine. And we have 2 consecutive postponement of the dates that was supposed to be last year, 2020, then was moved into April this year. And then unfortunately, we need to move away again and postpone in the end of August. But we are really pretty convinced that we will be able, and the situation of the COVID will allow us to make this course possible in the end of August. So please, all of you that know about the importance of this, you can try to take your inscription to the Academy. And this is an important project that we are running, starting possibly this year in 2021, that is the new ESSM Academy on Genital Surgery. So this is a pretty surgical project that is quite new and is based, as you can see, on 4 different levels, moving from the basic textbook environment video library to a dry lab, wet lab, and finally there will be a fellowship in the more important centers of excellence that we have in Europe for this skill. And so again, you can have a look on our web and possibly start to take your to book this for the next occasion. And the final thing that I want to tell you is about the videos, and we have already some very good videos on the knowledge of erectile dysfunction, but we are also adding some new videos on mainly surgical procedures. And so if you go on our website, you can start to have a look on these, as well as the books. You know that we have historically published these two very important manuals, one on sexual medicine and the syllabus on clinical sexology. Well, first of all, we are updating this new book, and so probably in maximum 2 years' time, 2022, we will be able to come out with a new version that will be very much updated. And we also have done a very important textbook on surgery. It is not only penile prosthesis, but is also urine sphincter and so on. So those are our important educational moments, and so you can really have a chance to use all of these things if you are part of our family, as I'm sure you will become in the next future. So now it's time for the main people, and so thank you very much, and really looking forward to see you soon.
Thank you very much. And now for the main event, and just to be sure, if there are any questions during the talks, we can collect them in the chat box and ask them afterwards if we still have time. I think Javier will start.
Give me 1 second, please. I will be in 1 second. Carpetas. Management, tal. Okay. Privacidad.
Javier, should I share the presentation?
I think I have it in 1 second. Give me. I think it is already. Is it okay? Can you see it now? iPhone, portable, PowerPoint. Joder. Andrea, are you ready to begin? Andrea.
At present, I think Andrea has left the meeting apparently at the moment, so I believe you should start. If you have any issues, Mikel and I have your presentation, so we can...
Yes, please. Can you put it? Can you share it for me, please? Thank you. Okay. Well, I am going to speak about the impact of the BPH surgical treatment in sexual health. Next one, please. So it is important to consider the different treatments for BPH that we can consider nowadays. The European Urological Association split these techniques in consolidated techniques and techniques under investigations. Between the first ones, the consolidated techniques, we have the most classical techniques like TURP, open simple prostatectomy, all the laser treatments, including green light, whole lip, tulip, and other electrical procedures. And also here is included for the first time the urolift, the prostatic urethral lift. The techniques under investigations are included the laparoscopic and the robotic simple prostatectomy, the eye-tint, the water prostatic ablation, more known like Aquabeam, and the water vapor thermal therapy resume that nowadays is increasing the number of patients we are treating with this new technique, and also the prostatic arterial embolization. Next one, please. So we can split it in thank you, like consolidated or like techniques under investigations. but also all the traditional treatments are the one you can see in the screen, and the new ones, the next one, please, and the new ones that are known as the minimal invasive treatments. So we are going to speak of traditional treatments, including till laser treatments, and we are going to speak about minimally invasive treatments from urolift, robotic and lap, simple prostatectomy, I think, aquabeam, and rectum. Next one, please. It is important that it is not clear what is happening when we are doing BPH surgery, and we can suffer from worsening, no difference, or maybe improving. All of these aspects have been described in the series. Next one, please. So when we are going to evaluate the sexual function following the surgery, it is important to say that this area, the sexual area, is uninvestigated or really very under-investigated in the majority of the studies. When we are studying and we are evaluating this area, the majority of the studies are using non-validated tools, so it is very difficult for us to compare the different sexual areas with validated tools and to have conclusions. And also that when we are going to speak of this, we have some confusional factors like the medicine, the pills that the patient is taking in the moment of being submitting to the surgery. Next one, please. The male sexual function is a complex interplay between psychological, neurogenical, vascular, and hormonal factors, and it is important that the sexual function have different domains: sexual desire, erectile function, orgasmic function, ejaculatory function, and sexual satisfaction. Only erectile function and ejaculatory function have been evaluated when we are speaking of the male sexual function. Next one, please. So only erectile and ejaculatory function have been evaluated, and in the majority of the cases, the erectile function have been evaluated with the IIEF, and for the ejaculatory functions, different tools have been employed, but the majority of them are speaking about presence or not of ejaculation. Next one, please. So why the sexual function can be improved or can be suffering worsening after the BPH treatment? Well, there are different ways to explain the worsening of the sexual function. The first one is for ejaculation. If we do an injury of the internal urinary sphincter, the patient will suffer retrograde ejaculation. If we are submitting a patient to BPH surgery, then the patient can suffer a psychological impact, and all of us, we know that the psychological impact will be having some consequences in the sexual desire, in sexual satisfaction, and also in erectile function. During the surgery, we can do some injury to the neurovascular bundle, and then we can suffer from erectile dysfunction. And also, when we are employing urinary catheter, we cannot submit patients to sexual intercourse. Which one is the explanation and the justification for the improvement of the sexual function following the surgery? Is first of all that we are doing a discontinuation in the medication, in the medical therapy that the patient is taking, and also because all of us, we know that the sexual area and lats, it's very well integrated, and when the sexual areas and lats, when one of them are improving, the other one will also be suffering some improvement in this area. Next slide, please. So the majority of the patients, and what is well established, is the majority of the treatments that we are employing till nowadays are provoking and promoting some retrograde ejaculation secondary to this damage to the internal sphincter between the prostate and the bladder. So the patient is suffering some retrograde ejaculation, and the patient will see that he's having an ejaculation. Next one, please. So as we were saying, we can have the improvement because we are stopping the medical treatment. So the consequences of this medical treatment will not be suffered by the patient again. As Dr. Salonia will show us later, the majority of these medications have an important impact in the sexual area of our patients. Next one, please. When we are speaking of sexual function, maybe ejaculation or maybe erectile function, it is important to evaluate and to know perfectly how is the preoperative erectile function, because some of these patients, when we are working with them, are patients with some age and they can be suffering some degree of erectile function. So it is important to evaluate with a validated tool before the surgery, how is the erectile function and how is the LATs. So it's important to evaluate before the patients. If we begin with the traditional treatments, we are speaking of the most employed treatment in all the centers around the world is the TURP, the transurethral resection of the prostate. If we look at the data, we can see that it is showing that TURP did not adversely affect the erectile function. More than that is that some patients, like in this study, 15% of the patients, it is not only not suffering erectile dysfunction, that is, they are suffering some improvement in the erectile function. And if we look at the data in the long term, the sexual function continue to be maintained in the long term. So TURP seems not to have impact in the erectile function. Next one, please. But TURP has proven to have a retrograde ejaculation in a high percentage of the patients that are submitted to this kind of surgery, being around 70–80% of the patients. If we look at this systematic review, it is impossible to do a meta-analysis of sexuality secondary to BPH because the data we have, it is not really good. We can see in this systematic review that there is no negative impact on erectile function, that there is a high prevalence of retrograde ejaculation, that there is no difference in sexual adverse events between a monopolar and bipolar resection of the prostate. And we have to say that this is the treatment that we are going to compare the majority of the other surgical approaches that we are going to speak in the next slides. Next one, please. Well, next one, please. Well, this is our data. We are working in a new, trying to do a meta-analysis or a systematic review about the impact of TURP. And if we look at the data at this table, that this is our data we are conducting, we are working on this, it is exactly the same. Evaluating the majority of the studies, we see that there is no erectile function. Next one. But we can see that there is a proven ejaculatory function worsening with a retrograde ejaculation that it depends of the series between 30 till 90% of the patients. Next one, please. If we compare TURP with lesser treatments, if we evaluate it and we compare it with the whole LEP, we can see that the erectile function, it is better in whole LEP than in TURP. Next one, but we need further studies to confirm this finding that whole LEP is impacting less than TURP in the erectile function of our patients. Next one, please. If we look at a retrograde ejaculation comparing TURP and whole LEP, we see that retrograde ejaculation is the same for both techniques. If we compare with TULEP, we see that it's exactly the same for both techniques. And if we compare with green light vaporization, we see that retrograde ejaculation will appear in the same percentage between TURP and all the laser treatments. Next one, please. If we look at our data, we are conducting this systematic review or meta-analysis. We don't know where we will finish. We can see that laser surgery will not impact in erectile function. Next one. But we have really contradictory results regarding the ejaculatory function. Next one, please. And we can see that the retrograde ejaculation depends from 6 to 76% in the series we have in the literature. Next one, please. When we are evaluating these techniques of ejaculation preservations, what they try to do is to maintain the most apical part of the prostate to avoid the retrograde ejaculation. We can see that the majority of them are reporting good results in these preservations, but this is a controversial data, and I think we need further and bigger studies to confirm this finding. Next one, please. Limited and heterogeneous data we have about it. So in summary, if we look at the traditional techniques, the TURP and the laser treatments, we see that definitely we have a worsening of ejaculatory function, with the majority of them suffering retrograde ejaculation. But if we look at the erectile function, we can see that the majority of the patients are not suffering erectile dysfunction, but some of them also are suffering some improvement in this area. Next one. If we look at the minimal invasive treatments, we are going to speak about Urolith. Urolith is this device that is like a grape in the prostate to open the bladder neck, like you can see in this part of the slide. Aquabeam is this water jet. The water jet is opening, is destroying some part of the adenoma, so it's increasing the flow rate at the end of the treatment. The iTint is a temporal implanting little device to open also the bladder neck and the prostate, and the Rethum is water vapor therapy to destroy some part of the tissue, provoking the adenoma. And then we have all these 4 minimal invasive treatments that are a really new technology. Next one, please. The previous one, please. So if we look at the urethral lift, the Urolift, we can see that it's considered a consolidated technique, and it is very important because the data we have about it is that we are not suffering any ejaculatory dysfunction with this treatment, as we are seeing in the European Urological Association Guidelines 2020. The next one, please. So if we look at this Cochrane evaluation of urethral lift, we see that the pool, the urethral lift, has exactly the same results as SAM for the ejaculatory function, and also it has no impact in the erectile function, so it has exactly the same results if we compare with the SAM. Next one. If we compare the urethral lift with TURP, are exactly the same results for erectile function. Remember, TURP has no impact in erectile function, and the urethral Urolift will have better results, less ejaculatory dysfunction than TURP. Next one, please. If we look at the data in this systematic review, we can conclude that the erectile function will be preserved and it will be stable during the time. Also, we will be seeing not only a dysfunction in the ejaculatory function, but also some improvement in the final data when we are evaluating it with validated questionnaires. Next one, please. If we move from Urolift to Rethum, the water vapor thermal therapy, we see in this report that there is no de novo erectile dysfunction, that less than 5% of the patients are suffering any grade of an ejaculation, and less than 5% of the patients perceive a reduction in the volume of the patient ejaculation. Next one, please. If we, previous one, please. Thank you. If we look to at the Cochrane, we see that salmon rectum has exactly the same erectile function also for the ejaculatory function. So we can conclude that rectum has no impact in erectile, neither in ejaculatory function. Next one. If we compare rectum with treatment with the data that we have from the METOPS study with dutasteride, we see that rectum has better results than any kind of treatment with finasteride for the treatment of BPH. Next one, please. Next one, please. If we move now from the water jet prostatic ablation, the Aquabeam, and we look at this Cochrane review, we can see that Aquabeam has exactly the same erectile function of TURP, no differences. Remember, TURP has no impact in erectile function, and that the Aquablation preserves much better than TURP the ejaculatory function. Next one, please. If we look at the data, we can see that the Aquabeam, the water jet prostatic ablation, has really very few events in all the domains that we are evaluating in the majority of the studies. Next one, please. Now we are moving to prostatic artery embolization, and we can see that the sexual dysfunction that is suffering the patients from this embolization comparing to TURP is fewer in the artery embolization. Next one, please. If we look at this systematic review, when we are evaluating the erectile function, the embolization in the majority of the studies has a better erectile function than the control. When we look at the randomized control trials, we don't see this effect of better erection than the control, but also the same. So we can conclude the artery embolization has no impact in the erectile function of the patients submitted to artery embolization. Next one, please. If we evaluate the ejaculation, the retrograde ejaculation, we can see that artery embolization will provoke retrograde ejaculation the same rate that TURP. Next one, please. Now we are moving to laparoscopic and robot-assisted simple prostatectomy. These are techniques under investigation and not accepted nowadays, not recognized by the European Urological Association. If we look at the erectile function, we can see that there is no worsening in the erectile function, and surprisingly for me, if we look at the data of ejaculatory function, we can see that there is no worsening neither in the ejaculatory function. So the majority of the studies report that they are preserving anterior ejaculation in a percentage as high as 66%. So for me, we have very limited evidence of this, and we have to do further studies to confirm these surprising results that the people is reporting. Next one, please. Now, when we speak about the iTint, the Nilitol device, we can see that we have really very limited data, and we have no reports of sexual or ejaculatory dysfunction. So we need further studies evaluating these results. Next one, please. If we look at the data we have in our personal, our group we are evaluating, all the minimally invasive surgery, we can conclude after evaluating all this study that the erectile function apparently have no differences from the baseline for this group of surgeries. Next one. But when we are evaluating the ejaculatory function, surprisingly, there is not only not a worsening, but also an improvement. This can be justified because we are taking out the pills, the medicines, the drugs the patient isn't taking. So when we are avoiding this medical treatment, the ejaculatory function can be suffering some kind of improvement. The retrograde ejaculation is only reported from 0 to 24% of the studies, and many of these studies report 0% of retrograde ejaculation. Next one, please. In summary, when we look at the minimally invasive treatments, we can conclude that these kind of treatments are a reasonable option to preserve the ejaculatory function, and that they are really achieving their endpoint, that is to minimize the sexual dysfunction and to be a very good alternative to treat these patients that they want to preserve as much as possible the sexual function. Next one, please. Now, as I told you, we are conducting this meta-analysis. I don't know if the data will be good enough to conduct a meta-analysis or we'll just do a systematic review. Next one. So in the next future, we will share with all of you our data. And in our systematic review, we can conclude that the majority of the studies are case series with no control group, that only erectile dysfunction and retrograde ejaculation are evaluated, that it is done with no validated and with arbitrary tools, that only the IIEF is employed in the majority of the study. To evaluate the retrograde ejaculation, the MSHQ ejaculation questionnaire is the most employed questionnaire, and that the other spheres of the sexuality, they are not evaluated in the majority of the papers. Next one. So I am concluding my presentation with the take-home message that all the sexual sphere is uninvestigated or under-investigated in the majority of the studies, that the majority of the BPH surgery seems no provoking or promoting any significant change in the erectile function, but the majority of them can significantly impact in the ejaculatory function, that the minimally invasive treatments can reduce the impact of BPH surgery on sexual function. The impact of BPH surgery on sexual function should be thoroughly discussed with the patients to allow them to properly prepare for any potential adverse events, and further well-designed studies are needed to clarify the impact of BPH surgery on sexual function and to compare the effects of different surgical treatments. Thank you very much for your attention.
Very much, Javier. Excellent presentation. Andrea, are you ready?
I'm trying to once again share my screen. Whenever I'm not able to, I will kindly ask you to.
Of course.
No, it doesn't work. I don't want to miss any longer. I'm sorry. Now, can you share my slide, Kit? Wonderful. Thank you very much, Mike. Well, good evening, everyone. It is a real pleasure for me to try and very briefly summarize such a huge amount of data dealing with the concept that in the everyday clinical practice, we try to improve the quality of life of our patients using medical treatments for BPH and mostly LUTs associated with BPH, but sometimes they may have a very bad counterpart dealing with sexual dysfunction. Next, please. The issue is, next one, please. The issue starts dealing with three main concepts which have been extensively discussed over the last 2 decades roughly, which is the first, erectile function, the second, ejaculation and ejaculatory disorder, and the third one is libido. Therefore, next one, please. I want to start with this very, very historical picture, which came out from one of the most important mentor overall and of every time, Irving Goldstein. He was able to share the concept that in men with an erection, at least with an erection, there is an important adrenergic block, which is important because the adrenergic blockade is really relevant to get an erection and to maintain an erection whenever at the smooth muscle levels inside the corpora cavernosa, whenever you do not have an adrenergic blockage, you cannot have even the erection. Therefore, whenever you are able to stop them all to work properly, you will be able to get an erection and to maintain the erection per se. So in theory, whenever you are going to treat a patient with alpha blockers, you should get a better erection or at least an erection as a whole. Next, please. In this concept, there is the issue of continuum of relationships between medical conditions, which have been extensively studied even in the field of urology and sexual medicine when dealing with BPH, LUTs associated with BPH, and on the other side of the coin, erectile dysfunction and sexual dysfunction per se. There is a sort of continuum of diseases. Next, please. In this specific field, the most important paper which has been published from the epidemiological standpoint has been the multinational survey on the aging male, which has been called with the acronym MSAM7. And Raymond Rosen was the one to deal with this important data roughly 2 decades ago. And what they found was that clearly the longer the presence and the higher the severity of LUTs, therefore both storage and voiding symptoms, the higher the probability of suffering from erectile dysfunction, which was also the case for ejaculatory disorders. This was even more important in older guys. Therefore, the older the patients, the higher the probability of having LUTs, the greater the probability of having erectile dysfunction. Therefore, from the epidemiological standpoint, this is very, very crystal clear. Next, please. In this specific setting, at least 4 different hypotheses, and still they are hypotheses in terms of pathophysiology, did try to link erectile dysfunction and LUTs. The first dealing with the concept of autonomic overactivity, which is one which clearly is connected to the idea which I presented at the beginning of my talk this evening, dealing with the concept of an adrenergic blockade. On the other side of the coin, there is something like inflammation, which is very, very relevant and demonstrated to be even more relevant throughout the last 5 years, roughly, in men who have been operated, or even more importantly, who have been treated with phytotherapy. The third one is a pelvic reduction in terms of nitric oxide and nitric oxide synthase. And finally, pelvic ischemia and atherosclerosis. They are clearly 4 hypotheses, very clever, but at the same time, still hypotheses. And they are able to link the 2 conditions, LUTs on one side and ED on the other side of the coin, even from the medical standpoint, the treatment standpoint, and the treatment management standpoint. Next, please. In this context, it should be clear that if ED and BPH are pathophysiologically linked each other, treating one condition should improve the other. Is that true? We don't know. Next, please. In this context, what we know is that clearly there is a sort of dose response. This is a paper which has been published in 2003 by Mauro Gacci and colleagues, and they were able to say that alpha blockers per se may promote an improvement in terms of erectile function. But even more important, this was not statistically significant. Please move. Thanks. Next slide, please. In this specific setting, more recently, the vice versa condition, which is alpha blockers, despite they were or not uroselective, are able to induce erectile dysfunction. And in this context, data on erectile function outcomes are certainly inconsistent. And most of the data were randomized controlled trials, for sure. Sometimes there were also cross-sectional studies. But at the end of the day, what I found was that something was happening, not that bad. For erectile dysfunction per se, was not associated with the use of alpha blockers overall. This does not mean that alpha blockers may be useful to treat erectile dysfunction in the real life setting. Next, please. In this condition, François Juliano et al. Did publish this very first paper dealing with uroselectivity versus non-uroselectivity. If you got to look over there, there is no even silodosin, and we are going to deal with silodosin later on. But interestingly enough, taking alpha-dosin as a sort of parameter to compare with, they were able to demonstrate that erectile dysfunction may be the case sometimes, even if uroselectivity was there. At the same time, there is one important issue that was the combination of therapies, thus including alpha blockers on one side and 5-alpha reductase inhibitors, thus meaning finasteride, on the other side of the coin. Once again, they could be associated with erectile dysfunction. Next, please. In this context, we published a few years ago this paper dealing with the first 100 patients who have been treated at our center from one single specialist using silodosin because of LUTs associated with BPH. We were interested on finding sexual dysfunction associated with this uroselective compound, which was greater in producing LUTs improvement, although it was associated with a number of sexual dysfunction. And indeed, next please, ED per se has been found in 11% of the cases, but it was not the reason for discontinuation and drop the therapy off. This is quite important in the real life setting, since whenever we are going to find a treatment which is useful to solve, for instance, nocturia, which is very bothersome and disturbing for our patients, they do not decide to stop and to quit treatment because of sexual dysfunction. At least the older the patient, this is reality, which is not the case for young men, of course. Next, please. In this setting, there is an important amount of data dealing with, for instance, phosphodiesterase type 5 inhibitors. They are considered mainly for tadalafil 5 milligrams a day, treatment for mild to severe and moderate to severe LUTs associated with BPH, even by the EAU guidelines on this topic. Interestingly enough, all those papers which have been published and associated in a systematic review by Romero-Otero a few years ago were able to demonstrate a sort of improvement in terms of erectile function, as well as an improvement in terms of LUTs. Therefore, sometimes treatments are able to do both. But what is important to me, there was a negligible change in terms of flow rate. So it is certainly important to deal with your patients, to have a comprehensive discussion with your patient, to spend good time with your patients in order to get their own expectations and needs. Indeed, for these gentlemen, having a better flow rate was not the case, was not that important. They did report an improvement in terms of self-perception of LUTs and bothersome from that specific standpoint. And at the same time, they retrieve a better erection. That was the case for them. Next, please. In this specific setting, my first question for you guys is, in the real life setting, whenever a patient is going to use a phosphodiesterase type 5 inhibitors and alpha blockers, do we have to wait for using a combination? Do we have to implement something like dose titration? Or should we use a molecule to be personalized, to, I would say, tailor our patients every time according to the type of molecules we do have in our hands? Next, please. The answer is quite clear. I used to use my EAU guidelines to discuss a few items. The first one is that there is a clear-cut indication to start with PD5 inhibitors, every type, mostly PRN, therefore on-demand PDE5 inhibitors, in patients who have been already on alpha blockers on a stable dosage. And this is the cutoff point to discriminate those who actually will have a higher probability of hypertension, therefore of side effects, as compared with those who actually probably will not. And this is the case in the real life setting from the very practical standpoint. Next, please. There is one more issue to me, which is 5-alpha reductase inhibitors. They have been discussed many times as anti-hormonal or hormonal therapies. And interestingly enough, they've been associated with a higher risk of having sexual dysfunction. In men who have been treated with 5-alpha reductase inhibitors, it is interesting to me that at least some meta-analysis, the one which has been published by Giovanni a few years ago, is really an important piece of science. Interestingly enough, was dealing with two main concepts. The first one is libido, and the second one is erectile dysfunction. Next, please. In this specific setting, it was able to demonstrate that that both finasteride and dutasteride were able to induce a higher risk of ED with a very important odds ratio of 1.47. There was no difference between the two, although they are completely different from the hormonal standpoint and the modality of action standpoint. But certainly speaking, they were able to promote hypoactive sexual desire and ED. And we will discuss the concept of hypoactive sexual desire later on. Next, please. In this specific setting, there are a few meta-analyses which were able to discuss the issue of whether this kind of treatment, which means finasteride mostly, could differently impact in patients whenever they are using this kind of compound because of BPH associated with or causing LUTS versus those men who are under treatment because of androgenic alopecia, which is AJA. In this specific setting, next please, Liu et al. Did publish this very important paper, which clearly demonstrated that in those taking finasteride 1 milligram a day because of androgenic alopecia, there was no erectile dysfunction, which was conversely the case for those taking both finasteride or dutasteride because of LUTS BPH. Don't be shy in asking your patients whether or not they do report sexual dysfunction, even because from the medical legal standpoint, we are not able to answer their queries whenever something will happen, even after treatment discontinuation. As you know, there is a sort of syndrome of long-term sexual dysfunction, and nobody has been able to answer their own questions from the pathophysiological standpoint. Next, please. In this specific setting, one more recent meta-analysis and population-based study, was dealing with the concept that there was a difference between BPH and androgenic alopecia, even in those who were under a combination of therapies, thus meaning alpha blockers plus 5-alpha reductase inhibitors. Next, please. And what I found was that, in conclusion, once again, 5-alpha reductase inhibitors did not induce a, I would say, worsening of erectile function, although the risk of having erectile dysfunction should be discussed across time. This means at a longer follow-up. These two results apparently are different and controversial. It is not the case. The one was a meta-analysis, This one is a population-based study, but once again, I would suggest you all to comprehensively discuss the issue of every single compound before your patients, before any kind of prescription for LAT BPH. Next, please. One more issue. There is a clear-cut indication that probably erectile dysfunction could be the one to be damaged along with libido and sexual drive. Next, please. This systematic review was able to tell us that the combination per se increased the risk of ED, but next, please. Monotherapy was not that different as compared with the combination per se. Therefore, once again, alpha blockers did not. Conversely, 5-alpha reductase inhibitors may do. Should we consider a nocebo effect when dealing with 5-alpha reductase inhibitor sexual treatment emergent adverse events? Next, please. My answer is certainly yes. This is the very, historical paper which has been published by Nicola Mondaini roughly 15 years ago. He was able to demonstrate that whenever you're going to discuss the patient with the patient's potential side effects, these side effects will appear more probably. Does this mean that our patients are completely stupid? I don't think so, of course. But certainly there is a placebo effect, which is quite clear, but there is even a nocebo effect, which should be taken in mind before any kind of prescription. Next, please. And therefore, don't forget that nocebo effects per se are adverse events produced by negative expectations. Next, please. In this context, phytotherapy, little evidences exist, which means that are they able to improve or to decrease quality of sexual functioning and erectile dysfunction? We do not have data enough to say that the very little impact from the androgenic standpoint of seroneurapins, for instance, is able to impact anyhow our sexual function. Next, please. Interestingly enough, this is an important paper which was able to demonstrate that long-term follow-up would demonstrate even an improvement in terms of LAT BPH because of a reduction in terms of inflammation. And this could be the case even for sexual functioning. Next, please. Interestingly enough, second issue, ejaculation. Next, please. In this context, data are suggesting that alpha blockers may promote ejaculatory dysfunction, mainly anejaculation, and uroselectivity per se is the responsible pathophysiology. Therefore, tamsulosin and even mostly silodosin are the worst in producing such kind of adverse events. Next, please. We did discuss the issue of retrograde ejaculation for many years, but probably we know that it is not the case for retrograde ejaculation, but for anejaculation, since they are able to pass the brain-blood barrier, and therefore they are able to inhibit the control of ejaculation at the central level. Therefore, our patients do not have sperm in the urine after masturbation or sexual intercourses or ejaculation as a whole. Next, please. In this specific setting, silodosin has been evaluated in our center using Q9 and Q10 questions of the IIIF, mainly ejaculatory frequency and orgasmic frequency. What we found was that the older the patients, the higher the probability of having this kind of, the younger the patients, the higher the probability of having this kind of disorders. Next, please. Indeed, what we found was that at the univariate and multivariate analysis, there was a strong correlation between both questions. I'm losing ejaculation, therefore I'm losing orgasm, and vice versa. But age per se was an independent predictor of both situations. Although, interestingly enough, effectiveness and non-treatment emergent adverse events were reasons for discontinuation at the multivariate analysis. Next, please. Even more important to me, alpha blockers demonstrated that there is a worsening of sexual function, mostly of ejaculation, with silodosine on top, although uroselectivity per se is the cutoff point for tailoring a patient according to the risk of having, for instance, systemic hypertension or a better result in terms of LUTS improvement. Next, please. In this specific setting, all data demonstrated that even 5-alpha reductase may induce ejaculatory dysfunction, which is not similar to the one which has been obtained with alpha blockers, but sometimes it has been called a low production, a low volume, a low power of ejaculation itself. Next, please. Even more important to me, phytotherapy does not produce ejaculatory dysfunction. Still, I do believe we do not have long-term data to say completely absence of side effects in terms of ejaculation or sexual dysfunction, but future will tell us how to proceed with, even with this kind of compounds. Next, please. We actually have systematic reviews telling us that the combination of tamsulosin and phytotherapy may be associated with ejaculatory dysfunction because of tamsulosin and not because of seronorepinephrine, for instance. Next, please. Libido, this last one. Move, please. Next. Well, what is clear is that the older the patients, the higher the probability of having low sexual desire. Pay attention to my wording, low sexual desire, according to the Lohmann study, which has been published 20 years ago, according to the US population. It was a US-based population study, very important. The older the patient, the lower the amount of sexual drive and sexual desire. Next, please. In this specific context, there are few pathophysiological pathways which have been associated with low sexual desire, that including low testosterone levels at the peripheral level, that meaning hypogonadism or testosterone deficiency. But please be careful in prescribing testosterone in men while reporting sexual desire disorder, since the probability of having primary hypogonadism with very low value and secondary hypogonadism with very low value is quite low, and therefore a comprehensive assessment of hypogonadism even in older guys should be always considered. Next, please. In this specific context, do we consider a commonly accepted use definition of low sexual desire or libido? Next, please. We don't. And indeed, according to the EAU, which also consider the International Consultation on Sexual Medicine definition, that meaning ISSM Society, hypoactive sexual desire disorder should be considered as a persistent or recurrent deficiency or absence of. But pay attention, from DSM-5, the concept of hypoactive sexual desire disorder means that you compulsory have to consider even a distressful situation, which has not been considered in this specific definition. Therefore, most of our data came out from different kind of definitions for the very same or for different sexual disorders. And therefore, the possibility to link the two conditions, treatments and the sexual dysfunction, is not that easy. Next, please. In this specific setting, alpha receptor antagonists lack major effects on sexual desire, no effect at all in roughly all studies. Next, please. This is very important since silodosine in our data, next please, demonstrated a sort of reduction of sexual desire in 7% of the cases out of 100 patients. And I'm sorry, it was the reason for discontinuation in 4% of the cases itself. That means that probably a psychogenic compound was responsible for, not only from the biological standpoint. Next, please. 5-alpha reductase inhibitors, they have been associated with low libido, although there was no difference between the two. And this is very important. There's no reason to say that dutasteride is less effective or more effective in terms of production or decreasing of sexual disorders, thus including libido. Gotta look to the odd ratio, 1.54. Next, please. And this is the case even for all data which has been previously demonstrated. This is very important systematic review which has been published this year by Salvatore Laviniera with many data associating cross-sectional randomized controlled trials and whatsoever, and the risk of having low sexual desire. Next, please. Combination therapy, once again, the responsibility goes to 5-alpha reductase inhibitors. Next, please. And this is clear from every kind of studies. There is no difference whenever they are combined or not. Next, please. And long-term follow-up will tell you that probably the longer the intake of any kind of 5-alpha reductase inhibitors, the lower the probability of having sexual dysfunction. But this is even more clear according to patient age at presentation and the onset of any kind of treatment. Next, please. Phytotherapy. There is no data to say that they may impact on sexual dysfunction in terms of sexual libido. Next. So in terms of take-home messages, what is clearly from my slides and from my talk tonight is that medical therapy for LUTs per se is potentially, I would say, at least potentially associated with sexual treatment emergent adverse events. The field needs, I would say, deserve research in terms of definition and long-term follow-up studies. And I would suggest everyone to discuss in the real life setting as much comprehensive as you can with your patients in terms of needs and expectation. This is a clear threshold to deal with potential litigations in terms of long-term sexual sequelae. Thanks a lot for your attention. I'm sorry for being that late.
You're certainly not late, Andrea. Thank you very much for a wonderful presentation with
Thank you.
Really a lot of information, certainly, but also very clear, I think, unusually clear. We have time for, we'll just do a couple of brief questions and then we'll end the webinar. The first one is, I guess it's for Javier, how about orgasmic disorder after BPH operative treatment? Is there any studies on post-operative orgasmic disorders as opposed to ejaculatory disorders?
It's a pity, but we have lack of data about that. It is true that in our daily clinical practice, some patients, they do report some these orgasmic disorders, and they say that since the surgery, they are not enjoying their orgasmic, and they are not only not enjoying, but also suffering some pain when they are achieving an orgasm. But there is absolutely a lack of any data in the literature about this domain. To my knowledge, I don't know if Andrea has any knowledge about that, but I have never read anything about that.
If I may, the orgasmic phase of sexual functioning is a very complex phase of the sexuality as a whole. Therefore, Javier is more than right in saying you that there is no data. I would say there is no crystal clear data to discuss this important, point of our, I would say, part of our sexual functioning. If I may, from the radical prostatectomy standpoint, we do have, and Mikkel is one of the most important researchers in the field, we do have data enough to say that surgery itself could be dangerous. This is the case even for medical therapy. Indeed, our data on silodosing were very clear in telling us that you are losing ejaculation, there is no reason for losing even the orgasmic perception, the orgasmic feeling, but they do. Why? We do have a psychogenic compartment, and we do have a biologic compartment, and we still have to study a lot. And I do consider ourselves very lucky, since in a very narrow field, there is so much to study, still to be studied, that we are incredible researchers for the near future. That's my personal feeling. And therefore, I'm more than happy to have our president here with us today, just to say that we do have so many fields to be investigated, yes, that you should provide us with a lot of money, since money are compulsory for building any kind of protocol up. Thanks a lot.
Thank you, Andrea.
And I think actually that's a perfect comment to round off the last webinar here. And this was the last workshop webinar from the ESSM leading up to our conference in late February. So please, everybody, do go to the website and sign up for our upcoming online events in place of the physical one. And again, Javier and Andrea, thank you so much for contributing to this. These were really wonderful presentations, very, very useful to the listeners. Thank you.
Thank you.
Thank you, Mikel. Thank you, Giovanni. Thank you, Carlo. Thank you, Daniela. Thank you, everyone who is attending this wonderful webinar. Thank you very much.
Thank you very much, all of you. Bye.
See you on Wednesday.
Yeah.
Thank you and good night.
Ciao, ciao. Bye-bye.
Thank you.